Welcome to the QZ-Anesthesia Commercial Payer Report. My name is Dr. Jeannie Cavillo, and I will be presenting on behalf of our research team, which includes Dr. Jeannie Skibisky and Dr. Sally Pepsel. The results will include findings from the 2019 CRNA Commercial Reimbursement Survey as administered by the Lewin Group. On behalf of our team, I would like to extend our thanks to the AANA Foundation for the generous grant funding that made this study possible. The reason why I felt this study had to be done is because we've reached the point in my CRNA group where we just can't compete with other physician-led practices in the community. I've been a practicing CRNA for about 30 years, with 26 of these years spent establishing an all-CRNA practice. And our group consists of 25 CRNAs providing service in about 30 facilities. And the reason we can't compete is because our reimbursement's about 75% of that of the anesthesiologists that we are competing with, although we are providing the exact same service. So essentially, our group doesn't generate sufficient revenue to offer similar benefit packages when recruiting CRNAs, and as the hourly rates are rising to $160 to $200 an hour, it's nearly impossible to recruit new staff. The majority of our revenue comes from direct payments from insurance companies and commercial payers, and commercial payers only make up about 35% of our payer mix. So because our practice is mainly Medicare, we heavily rely on these commercial payers for the higher rates to offset the lower rates. But we continually are forced to accept lower rates than the other anesthesia groups, and I know what they're getting because I've had procedures done at these facilities myself and reviewed the allowable charge. So privately practicing CRNA groups like mine must be offered comparable rates in order to fairly compete for business in our communities. So in the past, the first step I took to prepare for payer negotiations was to perform market research to see what the prevailing rates were. But guess what? No benchmarks have been established and no data exists for CRNA rates. And although the ASA reimbursement surveys are helpful, as we know, they're not specific to QZ, and theoretically it shouldn't matter since payers should not be discriminating, but we all know this is not the case. But here's the thing, it isn't enough to know or think you're being treated unfairly. You need to be able to prove it and then quantify it. And although this was a small study and bigger efforts are needed to more accurately quantify the disparities, the report is significant in its findings of disparity and discrimination, which proves the most important thing, that a problem does exist, which provides the evidentiary basis that supports the priority of enforcing regulatory compliance to ensure markets remain free and competitive. The objective of this study was to establish commercial rate benchmarks specific to the CRNA anesthesia delivery model, QZ, then provide rate comparisons to quantify any disparities that may exist, and then use these findings to determine payer alignment with non-discrimination provisions of the Affordable Care Act. But prior to commencing this study, there was no known database available that targeted CRNAs working in fee-for-service settings. So we developed a database from the ground up for use in our sample framework in a separate study entitled the CRNA Fee-for-Service Database, which was completed in 2020. The database that was developed was comprised of 345 CRNAs with experience in payer contract negotiations and had access to QZ claims data. I'd like to take you straight to the takeaway points, and then we can explore them further in the presentation. The national average payer rate for CRNAs was $58.62 per unit as compared to the ASA rate of $77.01. There is a 24% disparity in reimbursement reported between the two providers, even though CRNAs and anesthesiologists are providing essentially the same anesthesia services. The report finds a misalignment between payer actions and those intended by the Affordable Care Act, which negatively impacts QZ reimbursement and imposes an unfavorable, disadvantaged, or prejudicial position for CRNAs when negotiating contracts with payers for anesthesia services. Discriminatory payer practices were reported that included exclusions from network participation in commercial and state-authorized government plans, negative payer payment adjustments for QZ claims, payment denials related to licensure or scope of practice, and obstruction to timely contract renewal. And finally, the last takeaway point is that QZ services are prevalent in all practice settings. So when payers discriminate between providers by targeting CRNAs for reduced rates, they impact revenues across all practice types, not just CRNAs. 56% of respondents in this study reported on behalf of mixed practice settings, in which 68% of all claims were submitted under the QZ modifier. The Lewin Group administered this exploratory descriptive study of CRNA commercial billing practices. The survey was targeted at the fee-for-service database that was developed in a previous pilot study and included a cross-section of 345 CRNA known to actively participate in QZ services. The survey was separated into two sections. Section 1 focused on rates and demographics, while Section 2 focused on factors contributing to contract negotiations. The majority of the data we will be reporting today refers to results obtained under Section 1. Section 1 was designed to closely match questions and methods as used by the ASA surveys for comparison purposes. Similar survey questions were asked, the same adjustment factors were used to normalize all units to a 15-minute measurement, and both studies referred to the Medical Group Management Association for the allocation of states to specific regions. The study complied with principles established by the Department of Justice and Federal Trade Commission, which required the data to be at least 3 months old and 3 conditions had to be met. At least 5 respondents were required when reporting on each statistic. The second, no individual could account for more than 25% of the data reported in rates. And the third, the information had to be disseminated in such a way as to preserve anonymity. 41 respondents reported data for QZ services in 2019 on behalf of 1,089 CRNAs. 351,920 cases were reported, of which 127,888 were commercially billed, according to 144 unique commercial contracts. 85% of respondents were providing information on behalf of multiple CRNAs. And you will notice one respondent reported 92,400 cases with 34,300 commercial payers. This number made up more than 25% of the data overall and was ineligible to participate in rate calculations due to the DOJ conditions. In contrast, and not shown here, the ASA survey reported on behalf of a much larger sample size. Theirs had 290 practices of more than 8,570 anesthesiologists and 8,937 CRNAs. They reported on behalf of 1,125 contracts. So you can see how these conditions can play a significant role in reporting when sample size is small. Demographics and practice settings are reported by region in Table 3. Out of 1,089 CRNAs, 615, or 56%, reported QZ services in mixed practice settings that included both CRNAs and anesthesiologists. Both the southern and western regions reported higher percentages of QZ services in mixed practice settings, with the southern contributing 77% and the western region 68% of services occurring in settings where both anesthesiologists and CRNAs worked alongside each other. This could be an indication of increasing usage of the efficiency-driven anesthesia delivery models. And although I'm not naive enough to believe that the ASA is likely to be actively advocating on our behalf, I don't see them actively opposing our efforts either, since they stand to benefit from these efforts. Of the CRNAs working in mixed practice settings, 68% of all billing submitted involved QZ services. Table 4 provides the managed care summary by region. The survey asked for rates associated with the top 5 managed care contracts. More than 50% of 41 respondents reported 5 contracts with a total of 144 unique commercial contracts. As we show regional tables, it's important to point out that one respondent reported data spanning 2 regions with 70% in the southern and 30% in the western region. So adjustments were made to regional tables when reporting data from this respondent to represent the data according to the percentage of services reported. Because of this, regional tables show the western region with 3 additional contracts, and the respondent is counted twice under the end column. This table relies on 146 eligible contracts. We started with 144, added 3 for the western region, and removed 1 that didn't report data by region. You may also notice the total commercial cases dropped from the original numbers to 118,138. This is because one respondent provided information on 9,750 claims but didn't provide regional information. Overall commercial contracts contributed 35% of managed care business, with the Midwestern region reporting the highest percentage of 44.52% and the Eastern region reporting the lowest at 25%. Mean units per case nationally were 8.9, with the Southern region reporting the highest at 9.2 units per case and the Eastern region averaging the lowest at 6.1. And now we get to the fun part where we get to talk about rates. The national commercial mean rate is calculated here, and in this table we're able to show several different calculations. However, the number of contracts contributing to each result is different because each result must separately comply with the DOJ regulations, and the more detailed the reporting becomes, like you will see when reporting by individual contracts 1 through 5, the more difficult it is to meet the DOJ conditions without having a larger sample size. The overall mean rate per unit nationally was $58.62 per unit, with a range of $55.33 to $64.57. This result relies on 137 eligible contracts from the original 144. 5 were excluded as outliers, 1 was excluded due to missing information for contract rates, and 1 contract was suppressed in compliance with DOJ regulation in Contract 1 calculations. All remaining calculations are based on 135 eligible contracts, since 2 more, in addition to the 1 seen in the overall mean, were suppressed under Contracts 1, 2, and 4 in compliance with DOJ regulations. The minimum rate was $22.68, the maximum was $135, median for most contracts was in the $60 range, the 75th percentile average was 61 through 73.69 per unit. You'll notice that even when looking at the national average, which was the most inclusive level of reporting, 1 contract had to be excluded from the overall mean calculations. This was because this person's data contributed slightly more than 25% of all data in the study. And had we had just maybe 1 more respondent, this data could have been eligible in the calculations, which would have reduced the overall mean rate down to about $53 a unit instead of what you're seeing here. Table 6 gives regional rates. As we drill down by region, you see the results can no longer be reported by contracts 1 through 5. And again, this is due to the DOJ conditions that can only be offset with a larger sample. The difference in rates reported across regions is notable, as you see a 13% variation with the Eastern region reporting the highest rate of $63.97, which is $7.61 per unit higher than the lowest in the Western region as reported $56.30. 139 contracts out of the 144 were included in these results due to the addition of 3 contracts for the Western region to take care of that respondent with data spanning 2 regions. 5 contracts were excluded as outliers, 1 contract was removed due to lack of regional responses, and 2 contracts were suppressed in compliance with DOJ regulations. So even when reporting in the aggregate, meaning we removed details associated with individual contracts, we were still required to exclude 2 more contracts on top of the 1 originally removed in all reporting. The second section of the QZ survey focuses on other factors contributing to CRNA contract negotiations. Results were reported by 40 out of 41 respondents who participated in this section. 62% reported negative payment adjustments based solely on the provider's licensure or the QZ modifier. 25% were denied planned participation due to services deemed outside the CRNA scope of practice. 20% reported denials and reimbursement for pain management services due to inaccurate payer perceptions of the CRNA scope of practice. 27% reported they were excluded or denied participation in state-authorized plans, and most of these were reported by respondents practicing in the Western region. And lastly, more than a quarter experienced payer obstruction to timely renegotiation of contracts. So let's take a moment to review our findings. The non-discrimination provision was designed to promote cost-efficient healthcare delivery by emphasizing quality and performance as the basis for payment valuation rather than licensure when different types of providers bill for the same service. But currently, there are no regulations in place to ensure payer compliance, and instead, payers are trusted to use good faith efforts when negotiating contracts. But the intent of this act was to challenge the system to improve processes designed to reduce overhead and increase productivity without any loss in revenue. And hospitals and surgery centers are rising to the challenge by turning to efficiency-driven anesthesia models, where higher numbers of CRNAs can more flexibly provide essentially the same services while decreasing overhead expense. But here's the thing. When payers discriminately lower CRNA rates, they are effectively sabotaging these cost-saving efforts by redirecting these savings as profit for themselves. The non-discrimination provision of the Affordable Care Act wasn't intended to serve as a profitable windfall for payers at everyone else's expense, and they certainly weren't meant to be used by payers to prevent CRNAs from competing in the market. As I stated, is happening to our group since we can no longer compete with our benefit packages when recruiting CRNAs to work for our group. And why is that? It's simply because payers are keeping a chunk of the reimbursement for themselves. And the 24% rate disparity, along with all the other payer tactics used to limit CRNA participation as seen in this report, is evidence that payers require just a little bit more than good faith efforts to regulate their behavior. And with that in mind, we've come up with 3 recommendations. The first recommendation is to perform yearly analyses of QZ commercial rates and make them available to the members. We've identified 2 mechanisms to achieve this goal. On a yearly basis, we need to establish and maintain a representative CRNA fee-for-service database from which yearly reimbursement surveys can be performed with a larger sample size. And then every 3 years, we need to obtain claims data from the Healthcare Cost Institute, which consists of claims submitted by 3 of the 5 largest U.S. insurers, United Healthcare, Aetna, and Humana, then perform claims analyses to compare with results derived from the member survey data. The second recommendation is a little more robust, and I can provide the committee with additional detail. But consistent with the Affordable Care Act and the No Surprise Act, we need to consider remedies for regulatory compliance for commercial payers to prevent provider discrimination. The third recommendation would be to consider expanding the CPC modular content to mirror Council on Accreditation revised standards that have added education and competencies focused on billing and reimbursement practices. This will remedy any educational deficits on this subject matter in previously certified CRNAs. And that wraps up our presentation. In closing, I'd like to say our team has really enjoyed putting this together and sharing our results with you today. And although I'm sure no one here was shocked or surprised to see the results, we can all appreciate that we now have actual evidence to support these claims of discrimination and disparities, as well as a strategy moving forward. I realized that this was a lot of information to be giving over such a short period of time, and I'm sure many of you have questions. So I would like to open the floor for discussion, and I look forward to your questions. Thank you.